we'll run through it pretty quick. So this muscle is attached to the striated process. It kind of tethers the hyoid from coming too far forward. Digastric, same, it comes off the mastoids. These are going to be involved in cranial problems. They'll be involved in any kind of upper neck issue. These could be involved. The mylohyoid is if you push up into underneath your jaw, that's that muscular floor. Geniohyoid is kind of in the middle. The mylohyoid, then you have to strip the muscle that's the genio. And see, these are innervated by cranial nerves. So they're what they share with the SCM and with the upper tract is they have cranial nerve supply. Sternothyroid, this comes up from the sternum, the thyroid cartilage, and then on up into the thyroid cartilage, and then the muscle above that is going to be the thyrohyoid. It goes from the thyroid cartilage to the hyoid itself. Sternothyroid or sternohyoid. Omohyoid, this one's interesting. It anchors clear back here on the scapula. So it's sort of a tethering muscle that goes from the shoulder complex to the hyoid. What's that about? So you could think it has a lot to do with proprioception. These muscles are as important for structurally what they do as they are for as a source of information for the proprioception. Close that. Thank you. So when we test the hyoid, we basically just get on the hyoid and we try to hit a muscle. We start moving it right and left, up and down, push it back, pull it forward. And there's a weakness. Then we TL the muscle that we know counters that movement. So somebody come up here. Somebody who already told me they have a jaw issue. Yeah, sure. We'll have no shortage of TMJ samples. So I need a strong indicator muscle. It's not bad. Is it uncomfortable? And let's try your teres minor. Use that one. Teres minor is not a real, I can test it. Now, I'm going to come right on to her hyoid. Remember, it's kind of higher than you think. A lot of times you end up grabbing the thyroid cartilage, but really that hyoid is up. It's up there pretty deep. It's right there. I'm going to push this way and push out. Push this way. I'm going to push back. And there we get a weakness. I'm going to pull forward. So much. This way. So that would indicate that either the mylohyoid or the geniohyoid is involved, because they're all run the same way. Take your these two fingers, if you would, and I want you to just TL. Let's see, let's do TL like that. Yeah, just like that. So about halfway back. Now let's go over to one side. And go to the other side. We're on her mylohyoid. There it is. So she TLs the left side. So I could get real out there and use my circular magnet. See, we get the same finding. We don't there, but we do. So that's just another, way to tee up. This kind of enhances that. That's the side that got broken. We were 3.
Yeah.
So to treat that, I mean, without looking at anything else, to treat that, I would. This is a scar.
So I burned myself in my
My goodness.
It's too early in the morning.
Yeah.
Wait, today? No, it was 8 years ago.
Oh.
I wasn't paying attention.
Sounds really painful. So what I'm doing is I'm getting on that muscle and I'm just pulling as best I can and trying to pull those fibers together, spindly down. Trying not to create another scar. Oh, wait, we were doing the cherry. Now we'll go back here. I'm going to push your hyoid straight back, and that doesn't show. Now I'm going to push it back and to the right and back and to the left. I'm going to pull it up. So that's all that really stands out. But that's basically how we do the hyoid. Now we didn't check her for a bunch of other stuff. She had a broken jaw at age 3. Might she have an IRT pattern somewhere? Even though that's a long time ago. She could have an IRT pattern. So we would want to check at some point that. That might be timing with your TMJ. Any questions on hyoid? I don't want to get too down and dirty with hyoid. Pretty straightforward. The TMJ overview. These are all the things, the major components that can be involved with TMJ community, I guess. Anatomical parts. You've got a mandible. You've got a biconcave disc, which is kind of unique in the body. So you basically have two condyles instead of a condyle and a fossa. You've got 2 condyles, and then you have a biconcave disc that runs in between. It's kind of a unique design. For zygomatic arch, temporal bone, these are all where the muscles anchor. The sphenoid is, of course, the keystone of the skull. It articulates with all of the other skull bones. And, of course, the maxilla, hyoid, we just talked about, and then the teeth, and the first cervical vertebrae. Now, why is that? Well, first cervical vertebrae sits literally right almost up against the TMJ. It's just so if that atlas is out, it's going to affect vice versa. So jaw pain, jaw clicking, uneven bite, sometimes nothing. Sometimes people have no symptoms. They don't even know if they have a TMJ problem until I ask them to open their mouth, and they open their mouth about this much. And they don't have pain. They just don't open their mouth very far. We should be able to get 3 knuckles of the non-dominant hand in our mouth. Don't try that. Are you lefty? Oh, so you got your dominant hand. Almost. So anybody besides Nicole, anybody not able to get it? I barely. So these slides are kind of fun because this shows how much the TMJ is connected neurologically to the rest of the nervous system. To the motor homunculus. See how big the jaw is here, the face. Here's another, that's our little homunculus guy. Watch out for this guy. So the muscles that close the jaw, masseter, deep, and superficial. There's two layers. The superficial fibers run a little bit. They run sort of A to P. The deep fibers run a little more. The temporalis, 3 divisions. They fill up this temporal fossa. Internal pterygoid is inside. Internal pterygoid, here's the masseter. Here's the right side of the jaw. Here's the internal pterygoid. Here's the masseter, and here's the jaw bone. They form like a sling. So when you bite down, you're contracting the internal pterygoid and the masseter on this, and on this side. Lateral deviation, you're going to have, like, if I move my jaw to the right, it's going to be posterior temporalis. Here, probably a little bit of anterior temporalis. External pterygoid and internal pterygoid. And this is grinding, protruding, retruding. These are all the different divisions that we're passing. Jaw opening, you got suprahyoid muscles. External pterygoid, which are way up in here. External pterygoid actually has 2 divisions. And of course the digastric, and gravity. So, but none of those muscles are big. So that's why we tend to have an overpowering of the closing muscles. You don't see people walking around like this too often with their jaw just too relaxed. Most of the time we see people. It's amazing when you have patients and you're taking a history and they're talking like this, telling you about their stuff, and their jaw is barely opening. That's a good indication you want to check their teeth and their diaphragm and a few other things. But people talk like this, break open their mouth too far. So jaw protrusion. I had to fix this slide. It was a typo, and I realized last time I taught this stuff, I must have that's wrong. But bilateral inferior, the bilateral external pterygoid helps protrude the jaw. It's the lower division because the upper division actually attaches just to the disc. Bilateral anterior temporalis. Jaw retrusion is going to be posterior temporalis and the deep fibers of the masseter, the ones that run back this way. So before I examine someone's TMJ, I always have them do those motions, and I can tell a lot. I say retrude, and they're like, I don't know what that means. Retrude, and they're like, and they can't do it. So you get work cut out because their jaw isn't going through its normal range. Anyway, there's the masseter. Now, the zygomatic arch, remember we talked last session, I think it was, about sutural faults, how this is a really common site of sutural fault jamming from, hits, and also from the pull of the TMJ. You got the strongest muscle in the body right here, pulling on that bone. So I think you can kind of, the superficial fibers are more this way, and then you can kind of see that's the posterior. The deep fibers. I don't think there. You get the idea. So temporalis builds that fossa, and what else is right there that we learned last session? TS line. Interesting. So the TS line is basically right at the border of that temporalis. So those little nodules, little BBs under a raw slice of bacon that we talked about that we find in the TS line, those are most likely little trigger points from the temporalis. They're little like periosteal, disruptions, O&I things. So trigeminal nerve, fifth cranial nerve, both motor and sensory. Temporalis closes the mouth, clenches in, closes the mouth. Here's the nerve. Quick, I threw this slide in here just in case you wanted a quick review of cranial nerves. You guys had to learn these, right? I know we did as chiropractors. It's interesting that 4 of the 12 cranial nerves are devoted to the eyes. 3 are devoted to the movement of the eye, and 1 is the optic nerve. So some of them are motor and sensory, and some are just sensory, like the olfactory and optic. Trigeminal is both. We're looking at the jaw from behind, as if you cut away this part of the skull. There's the turbinates and the sinuses. Here's the pterygoid plates. This is the internal pterygoid. Out here is the masseter, hence the sling. This is your external pterygoid up here. So you can reach the lower division. I'll show you how. The only thing you can do is basically get on it with a pinky and just gently kind of stretch the muscle. That's, you can't go in there and spin the lid, can't pull an eye in. You just get in there and just, I'll show you how I treat. It can be life-changing for people if they haven't had their TMJs. They've been struggling with it. These are really, there's some really wonderful tools in AK. I don't know how it is down here, but we have almost no dentists in our greater Portland area that really do TMJ. We had one, he was a specialist, he's retired, but he charged just a huge ransom for his work. And honestly, I thought a lot of fairly mixed results. He did, but everything he did had to do with changing teeth and bite splits and all that. And other than that, none of the dentists in my town do TMJ, and really most of the PTs don't really do it, and most of the chiropractors don't. So there's a huge need out there for TMJ work. So anyway, internal pterygoid, trigeminal nerve, external pterygoid. So the superior division is basically, its job is to hang on to that disc, and as the jaw opens, kind of bring the disc forward, and then as the jaw closes, it kind of helps. It helps, tether the disc so it doesn't go too quick. That's what that muscle is designed for. The lower division actually attaches to the condyle of the ramus, and by pulling that forward, assists in opening the jaw. That's the one we can get at. So if somebody opens their jaw and they go like this, you can assume a number of things, but one thing you want to think, check is the contralateral. If it's going to the right, check the left external pterygoid. There's a 10, there's a 5, trigeminal nerve. This is the best picture I could find. Here's that disc. Here's the upper, they call this the SLP, they call that the superior lateral pterygoid. Some texts will call it the lateral pterygoid instead of external. It's the same thing. Two names. Here's the inferior division. So it's attached, it pulls the condyle. This one here goes up and tethers that disc. I did that slide. Okay, here we go. Neurovascular points. The side of the ramus, pretty easy to remember. The neurolymphatics for the TMJ are the same as serratus anterior and a bunch of other lung muscles. Here's the stress receptor right there. Okay, so before we treat TMJ, if we had that with, what did we do teeth on last one? Yes. She's not here. Okay. Oh, that's right. We did teeth, 3 different teeth we found. First thing we did is we tested a strong indicator muscle. We had a bite down. She bit down, everything went weak. Then we went and we TL'd tooth gum line, and we found 3 different teeth that responded. We did a challenge, rebound challenge, breath in, breath out, and we treated the teeth. So, whoever wants to volunteer, check you for neurological tooth. You have braces too. So. Braces are tough because they're so go ahead and get on your back. And now I probably would check a whole bunch of stuff here. Close your right eye. Left eye. Eyes open, look up. Straight this way. What am I doing? You okay? This way. So to the left. She only weakens on eyes to the left. So what's that tell me? Maybe. Probably. C2 on the left. Most likely. But how do I know it for sure? I don't. I come in here and I'm going to just do a challenge on C2. And I do. It wants to be A. So breathe in. So I'm just going to do a respiratory just to so it doesn't come up again. Breathe in again. And again. Just a little, just kind of clean it out a little. Okay, so hold there again. Eyes to the left. Now there could be, oh yeah. There could be other reasons why that's C2. Maybe it'll come back. Maybe I need to address something. But right now, we kind of got it out of the way. It's not going to be. Now, bite down. Okay, bite down. She doesn't weaken. That's good. So she probably doesn't have neurological tooth. Good big. We've got weakening when we open. Okay. So we will use that, but open big. So when she opens, everything goes weak. Now, put your 3 fingers from each hand, go right on the masseters. Open big. I'm TLing, she's TLing her masseters because they're being stretched when she opens, right? Now come up and spread out and touch your temper house. Okay. That negates it. Which side is it? We don't know. Oh, one side. Yeah, hold one side. Okay. That side's probably what tests the other side. Yeah, so it's the right side. Which division of it? We don't know. Anterior, middle, posterior. I mean, anterior, middle, posterior. Go here, 2 fingers. Why do I use 2 fingers? What's that?
It's a better TL.
Clear TL, and I, if there is some factor of the charge, positive, negative, it's likely neutral. Okay. Go to the middle division, open big. Go to the posterior division, open big. Okay, go to the middle division, open big. Okay, hold. So it's right at the front part of the middle, it's right here. So the treatment, when we find that, and we will get back to the tooth, I promise, is spindle down. So I come in here and I'm just going to spindle down, spindle down her anterior and middle temporalis. Open big. And she doesn't show. So it's that, can be that simple. That just cleared that part out. Now come back to your TL and you're going to touch the TMJ itself, the jaw joint itself, bite down. Now with her TLing biting down, she gets a positive response. Without TL, bite down, no response. So, but when she TLs, now that tells us that we've got a muscle spindle issue. So if she bites down, it could be masseter, internal pterygoid, or the temporalis that need to have their spindles reset. So we don't know which one it is. So I'm going to have you go to the masseter and bite down. Other masseter. And there it is. Okay. So I'm going into the masseter, and I'm first going to do the superficial spindle up, and then I'm going to do the deep. And it's just, I just changed my vector a little bit. And TL your TMJ.
Both sides.
Just, well, yeah, both sides. And bite down. Okay, good. So that, got that. I'm getting lucky here. You're happy. So, so that would be it, really. Now, if she had weakened with TL and opening, then we would have to go in and look at her external pterygoids. We wouldn't do that again. TL again, I don't think we did that part. Okay. No, we didn't. It doesn't show. So right now, I mean, even though wouldn't you have your braces adjusted? Oh, okay. So you're right now, you're pretty good. It'd be interesting to check you right after an adjustment. Yeah. So anyway, that's that. Now, there might be more we can do with that. You're better than you thought.
Yeah, thank you.
Anyone else have TMJ that they know of or don't know of? Yeah, well, I'm looking for a neurological tooth. That's what I want to fix. Hopefully you'll have one. Now, we could go through and make sure we're a testable person. Close your right eye, left eye, eyes up to the left, up to the right, down to the right, down to the left, up to the right. So what's that tell me based on ocular volume? Anyone else? So would we want to clear that before we did TMJ? Probably. Now let's go in here. I'm going to get a hold of your hyoid. Push your hyoid this way. Now that's interesting. If I push your hyoid this way, what attaches up near there? Stylohyoid and the other, I guess. Now, eyes up, to, so when I stretch it this way, she goes weak, eyes up to the right. That negates it. So do you think her occiput is having an effect on the hyoid or vice versa? So which should I fix first? I don't know. I know I'm getting off the weeds a little bit here. Okay, so eyes up to the right. Straight ahead. So I'm going to fix the hyoid first because we did priority and the other one went away. This one stayed. So, now that won't be on your test. These things aren't, they're kind of outside of the mainstream ICAK curriculum. So I'm going to go back and just trace that muscle. And just kind of fashionably flushing this. Nice up into the down straight ahead. See that clearly. Now, like we did the first time, eyes up to the right. So that cleared that. Now, since we're doing good with this one, go ahead and bite down. She goes weak. So, do you mind putting your finger in the mouth? Now, okay, so we don't know which tooth is involved. So we're going to do kind of a scan. She'll take her index finger and she'll touch starting in the back, lower molars. She'll touch the tooth, gum, line, 2 or 3 teeth at a time, and we'll just come around and tee out. Find the tooth that way. You guys with me so far? Upper? Right there, something I think. Go back a little bit. Right there, yeah, okay. So can you remember which tooth that is? Is that like your second molar? Okay, now come on. Try that again. Okay, so we got 1. Sometimes we got 3 on somebody last night. She's gone, that's right. I usually don't find incisors so much, but last night she had an, what's her name? It's here. Rafi had a front incisor, which I don't see too often. So I'm going to put gloves on, and I'm going to go to the tooth that we did find. Now, if I'm doing this in my office, it takes, a fraction of this much time to do. The most challenging thing with doing these tooth adjustments is being patient, because you're doing something that's quite invasive to the patient and sometimes very strange to them. They've never had anybody but a dentist do anything with their teeth. So let's see if we can guide you to the tooth with the upper right hand. So right here. So I'm going to challenge from lateral to medial 3 times. That doesn't do anything. I'm going to go inside. I'm going to challenge. Feel the lateral. There it is. Now sometimes you got to get real specific with the vector. Push straight up. Sometimes I'll push them straight up and I'll get it positive. Sometimes I'll pull them down. But with you, it's right there. So breathe in, hold the breath, and it strengthens on a breath in. So how am I going to correct it? It challenged this way, and it strengthened on a breath in. Same way. You go in the challenge direction on the phase of respiration that you gain in the challenge. Everybody's with me, right? Same with cranials. Same with rebound challenge and respiratory adjustments on the spine. So go ahead and open. And so you're going to breathe in and out. And again. And again. Give me one more. It's about the same. It's about the same amount of pressure you would use on a cranium. Not a lot, but you'll feel, after you do a few hundred of these, you'll feel the spring in that tooth. You feel the periodontal ligament. That's what you're really setting. Okay, so that's the general screen. She doesn't weaken with biting now, so I'd be ready to move on to the next thing. Now, open big. Protrude. Retrude. Go to the right. The other way. Yeah. So the other movements don't seem to show much. Now, TL, or TMJ, and bite down, and open big. Now she does weaken, TL on open. So take one hand away, because we want to find out which side open big. Go back, oops, sorry. Open big, and it's the left side. Same side as the tooth was. Now, the way we treat that, because the external pterygoid is the muscle that's involved as far as our approach to the spindle part of the thing. So I'm going to go in and try to reset her external pterygoid. And because I can't go in and do this or do this, I'm going to be just putting my pinky into the muscle while I have her jaw kind of moving to the same side. It's that muscle. So, you guys, if you want to gather around and see what I'm doing. These are now these are very uncomfortable. They're very uncomfortable, and so make it as comfortable as possible. So first thing I'm going to do, we are going to go in and do the thing and ask you to open your jaw. This is kind of outside of what you'll find on the slides. This is how I assess the jaw. I put both thumbs in her mouth, gently bite down. When she bites down, I can feel how even her bite is. Now let your jaw relax. When she relaxes, I can push her jaw back. I can feel it's a little tight, okay? Now I'm going to pull it forward, back. Ideally, I should be able to get kind of a drawer effect on a jaw. Yours is kind of tough. Most of them are. So test it after we fix it. But now, open your jaw. See what happens to your chin. You see that? Slow. Slow. So her jaw is deviating to the right. So her left external pterygoid is firing too much. It's ahead of the right. So here's how I fix it. My pinky. Let your jaw relax and then pull a little bit to the right. Can you feel that? Now let it relax. There's the muscle. You have never forced it. Now I'm going to try to feed this jaw back into its place as I stretch that here. I feel like I want to give my patients suckers. Balloons or something after they go through. Okay. Still deviating. Now I'm going to come back in this way. Now let that. See if we can. What's happening is her disc doesn't want to ride back into its proper position. It's wanting to stick forward. So my goal is to get that to normal. Now let your jaw relax. I'm going to take you to your jaw. There you go. Here, it's just like cranials. You have to be subtle. You're working with delicate, highly innervated structures. You're super invasive into the patient's stuff. Relax the jaw, especially close. Relax. I'm having trouble getting it to go back. There we go. That's really tight. That's way. That's better. It's actually better. I'll let it relax. Let it relax. That's better. Let's leave it for now right there. That's better. Feel this out. And peel, and then open. So it's not TL. See if you can protrude. So she had a neurological tooth. We had to fix that first. Then we found an external pterygoid classic. These are really. This is a very common presentation. And basically, that's how you treat external pterygoid. Just try to get that. I'll get pressure on it. You got to monitor how they're responding. At some point, you'll kind of feel the muscle. That guy once, a few years back, probably 15 years, he came in and he had a TMJ issue. And I went in and I did that and a couple other things, and he screamed. Screamed and he cursed. Just like it really startled him. It really hurt him. And he's just, and he had a parasympathetic reaction the whole bit. I'm like, oh, okay. And I said, we'll check it in another week. Reschedule you. Okay. And then he left and rescheduled. Well, then he called up a week or so later, canceled his appointment. I'm upset. Hurt him, freaked him out. Just had a bad feeling about it. Eventually, I got over it. About a year later, he's on my schedule again. So I go in and it was a whole different thing. And it came in with a different problem. And I said, well, how's the jaw doing? And he goes, oh, it's fine. After you did that thing, it hurt like heck, but I was fine after. That's why I canceled my appointment. Here I've been fretting all year that I, somehow, Sometimes it's good to do a follow-up call on people. Just free roaming peace of mind. Because I tend to just overthink everything. Anyway, that I would ask you to do TMJ exercises. And the two main ones that I give to people are the lion, with like 3 breaths. And then the other one, well, there's 3 really. The other one is to have them their thumbs on their jaw open big. Just get the jaw to kind of translate forward. And then gently pushing in as you open. Keeping a little pressure on it. That will help kind of bridge that disc divide where it's supposed to be. The condyles of the TMJ, when your jaw is closed, they're back and up. When you open the jaw, they translate down and forward. There's different motions going on. Gliding, translating, and so it's a complex motion. And so it isn't a simple hinge. Any questions on? I'd like you guys to all feel this. Yes. You have enough gloves, right? On each other. Let's run. Let's see if I miss something on the slides.
Are you ready? For something to never mind. I was gonna say. No. So we're doing more slides.
A few more. Oh, no, okay. Yeah, let's do a few more slides and then we'll get into them. Anybody have questions so far? Everybody follow what I was doing.
Pretty much.
So it's the same principles that we learned in session 1. Because you can't test the TMJ muscle like you can another muscle, you have to use TL while you're testing the strong muscle. It's a little bit of that. So neurological tooth, no TL, no other factors, bite down, suspected neurological tooth. It could be something else, but often you won't know. Say you think it's a neurological tooth and you go in another TL, well, it's probably something else. So here is, you can see how this is a very similar to the TS line. And there's some holistic dentists that actually study this stuff, and they kind of look at TS line, they look at the dental. There's a relationship between each tooth and a certain muscle. Remember TS line, you had, well, on the TS line, you've got 2 SOAS. It's please, please, quit singing, please. That's how I wrote it. And then the other one was he quietly gave the girls something. That's how I got through the different. Here's the sphenoid line, so you can kind of compare for the TS line. So the periodontal ligament, here's a kind of a weird slide. The periodontal ligament is highly innervated. And that's what tells our brain to turn down the motor signals to the masseter when we're biting down. Otherwise, we might just keep biting down because we broke a tooth. So the periodontal ligament is giving constant feedback to the brain so it can dial in the amount of motor signals that are necessary. Now, what happens when you have a tooth removed? You lose a tooth. You lose that source of proprioception. I have an implant. I got my lower incisor. No proprioceptive input coming. So, yes.
Do you see that wisdom?
You know, with wisdom teeth, a lot of times I'll find IRT related to wisdom teeth. If it was a real nasty extraction, mine were bad. I had mine done many years ago, and they had to break two of them, and it was, yeah, I was really messed up. Until I started getting AK years later, I was always having issues. But yeah, that's a common source. That's a common IRT pattern is wisdom teeth, and any other kind of dental issue. Root canals will often, and a lot of root canals are problematic. A lot of times they have like low-grade infections in them. And a lot of times teeth will TL for. So basically, TL the tooth gum line, and then when you challenge it lingually, challenge it brutally. Once again, zinc is important for teeth. Zinc's important for cranials. So zinc for cranial, zinc for teeth. If it happens to be on your test. So if a strong muscle weakens with biting, think neurological teeth. If strong muscle weakens with opening, you're thinking you've got hypertonic muscles that need fascial flush, which so there's the masseters, you can fascial flush them, which we did. Fascial flush the temporalis, figure out what we spindled down, I think. Who's we did the spindle down on? You, yeah. So it's the same as first session. Spindle down, spindle up, fascial flush. Those are the key tools. Flashing the internal pterygoids, those are the ones inside the jaw, those aren't very pleasant. The way you TL for those is you have the patient put the thumb just underneath it. That will TL them, which we didn't find. Strong muscle weakens with TMJ therapy localization because you're going to use spindle down. So once you fix the fascial flush, then you have the patient TL the TMJ. The any opening or closing is going to be a spindle issue, which it was with TMJ. So anyway, we'll work it out this here in a bit. So I'm spindling down in this slide here. That shows a spindle down of the masseter. You can also spindle the masseter up. The masseter almost never needs spindled up. It needs spindled down. It's almost always too tight if it's having a problem. Spindle down the temporalis muscle. It almost never needs spindled up. And with the internal pterygoid, you know, just the best you can is go in there and just kind of get in the middle of the belly of the muscle. So if the mandible deviates away from the tight, the mandible will deviate away from the tight pterygoid. We deviate it to the right, the left external pterygoid. That we had to treat. Is again Chapman reflexes, the vascular right on the jaw. So this just gives you some. If you're as you're testing it, you can look at this recipe here. So if the patient weakens on retrude, dealing with posterior temporalis, mostly, and deep fibers of the mass. The click, click is because the disc is either holding up in the forward position, and then it's like kind of, if the external pterygoid doesn't let go, it has to finally pop into between the condyles. You can also have an opening click. An opening click is where the external pterygoid isn't working enough, and the disc is kind of hanging here, the condyles move, and it kind of like, does that. So the click is where the disc gets held up and then released. And clicks are really common. And sometimes I can't fix clicks. I've had TMJ issues where I can really help them in a lot of ways, but the click is sometimes hard to get rid of. Because the click has been caused by some thickening of the disc. Irritation. Opening click, it's going to be external. Either way, it's going to be an external pterygoid issue. The clicking. Closing click, possible hypertonicity of the external pterygoid. Closing click. That's probably a misprint. Usually, on a closing click, the disc is kind of hanging forward, and it's reluctant to slide back because of the hypertonicity of the external. So this is a typo. I apologize.
Wait, can you go back to which part is the typo?
Okay, what?
Which part is the typo? Can you go back?
So there's a couple possible hypertonicity of the external pterygoid superior division. It's most likely going to be a hypertonicity. So this is a technique Dr. Francis used to use where you stand behind the patient and you kind of spread as they open, and then as they close, you kind of keep the spread on. I don't use this technique. It doesn't work as well for me. What I use is basically what I was doing where I was holding the jaw and getting the patient to open and close and trying to get that glide. And your glide is pretty tight. Now, some people, they just move lots of ways. And sometimes they move on one side but not the other. My goal is always to get the TMJ to glide back and forth without without the muscles activated. Okay, so we will not go to that yet. Okay, so let's do this. Okay, we didn't workshop. We workshopped the elbow wrist muscles, right? So we didn't workshop. Okay, let's all check each other for biting down neurological tooth. See if we find some more that we can fix, and then we'll go to the TMJ protocol. You can also, hyaloid. We didn't workshop the hyaloid. So what I'd like you to do, get with your patient, find a strong indicator muscle, find the hyaloid gently, and I will come around and help you if you need help. And find the hyaloid and start moving the hyaloid forward, see if you get a change. And then we'll do neurological teeth, and then we'll do TMJ. Yes,
The dry lab, for whatever reason, is like oh. Yeah.
Everybody find their own highway first, so you know where your highway is. Moving back and forth, it kind of goes.
Is mine moving?
Now there's two guys. There's two ways to do the highway. So you can find a remote indicator muscle and have the patient touch and move their own highway. Or you can use an indicator muscle like a PMC and use your other hand to move it. Because it's a static challenge, basically. If you have a patient move their highway and then they have a positive, then you can have them go ahead and tee out the different muscles, and that's how you're going to find the muscle you need to treat your muscle.
Oh no, my throat is just. You are testing. Oh well, wow! Look who actually got a fucking hang. It hurts. Okay. It like forces my hand into a position that hurts more than if it wasn't. So that's why I'm taking it out nonstop. Yeah, one guy. I think you're practicing on me. I just can't really I can't.
Wait, is it, is it
I just.
alarm? I think it's, is it 5 and
Should have been here.
5 3?
I'm just
Get
kidding.
rid of it. That's why I was like, hold on a minute. Not wrong. So it's 7 and 9. 7 and 9. Okay.
Mine's really crunchy. She's crunchy.
Okay. I think it's my digestion.
Why is it like that?
Oh, this one.
Why is it like that?
Okay, so how about we do this? How about I can see it. There's two.
So everyone can
You keep one you keep one of this. That's why I keep doing that. Yeah, it's
She would listen. Can you cut it out? What? Of the video? Sure. I usually cut. I said I need to. That's okay. That's so good. I hit Heather in the face with a carrot. She threw a fucking carrot. If I didn't wear mirrored on her glass. She's like, I was gonna eat your hand. I know, I literally was. What'd you do? She brought that elbow back and she doesn't even go baseball. What would you do like they should have just got? There she goes. Okay. But yeah. There she goes. Wait, why do you keep taking that off? Because I can't. I would have her lie down and not have her open. We're technically you're supposed to screen to you. That's fine. My highlight or my dead? You gotta get your sex pocket pills. Yeah, that's what he was saying. He didn't touch my side. Maybe I just like twist it off. I was like, yeah, get down in there or something. Here. So you can. I did this. Or you just go down. Okay, close the other. Okay, that's one. Wait. She closed her right eye. So, and I'm curious now. What did you prioritize? Test. Yeah, and also it was working, so we could just you can straighten that. Okay. You, when she closed which eye? Yeah. All of it. Okay, go ahead. This like right under and like yeah. And she's doing so it's okay. Now Teal's a Tuesday. She just makes ones. Yeah. Oh. Okay, lots of times you need to have
And that negated the text.
I don't think he did that specifically.
Now, who do you message? I'll find this one.
Okay. I know, you can't tell.
Yes.
Oh, are you done?
No.
Oh, you never. Come back. Yeah.
Come watch this if you're stuck. And they're gonna. Come back to where the back was.
It was in like. Yeah. Sweep, sweep, sweep. So that doesn't show. Enjoy it. Oh, there's water. This is small intestine right here. So I would jump over it. So the small intestine along.
So what I'm doing is you have the
Spot
spot
for
in
the
the
muscle.
muscle. Open the jaw.
And
So that you close this
that's
down.
the
Punch down. See if it goes. You get this open. Open it. See if it goes. Push on it. See if it goes. Shrink. See if it goes. muscles, so you can
Strong muscle.
steroids, but mostly it looks like the acid.
So you guys have some pictures to see. Put her face down.
Yeah. Wait, right? It's just like kind of like an SI, no?
I choose to smell it.
Oh, there's. Yeah.
So if we go.
What's the difference between
Or that.
versus SI?
When you're adjusting the safety, you're adjusting the safety. You're adjusting the lung.
Wow.
So you might adjust the same stuff. But your approach, your vector is different. Yeah, so this, that's the same. Now, that's,
So it was weak on open.
She's like, sure, you think so?
is.
Okay. Yes.
But I'm adjusting this.
So if we say.
So, now it's going to go around this side. So here's the same. Last adjustment right here. This time. So I'm going to get way over. I'm going to bring the same this way. I'm sorry. Now.
Yeah, it's a. Yeah.
But you could have done that with the spark, or you could have done it with the activator. It would have been slower. It's just a little longer. Touch your camshaker. I did not show
My bad.
That's what we're looking at.
now. let's do it, and then we'll see. But if you have that, now,
And then it's like going like this.
now, last thing I'm gonna do, because we have
So here is what your close job, spindle cell down.
thumbs.
No, I was just.
That let's settle in for us.
So, that's strong, you see,
So,
I'm sure. No, there's no way. They didn't know. So I was like, what? That's not why I went to prom. So very, yeah, that's why I was like, I know. So my mom's like, no, it's like the location is weird. So to just be in there, like, no kind of work. It's like in your it's like it feels like you're in the world. Not this time. Not this time. I don't think really. Yeah. Oh, I'm gonna do it on myself. I think it was it's like between the Yeah, she doesn't need it. No. No. The other day, she nearly jumped on the table every point. And I'm like, she doesn't need that. You know? I love it when you're really? That's true. I do feel like kind of like a rise of like celebrity is weird anyways. Yeah. Yeah. Because usually what I do, I put it in if I feel resistance, I don't put it in. And some people do, and I'm not supposed to do that. Well, that's what I'm saying. Some people are so kind of passive resistance, so I don't do that. That's weird. Yeah. Yeah, those. Yeah. Gets me, like, well, usually I feel like if you don't feel anything, it's as long as it's not and you don't feel anything, is it the right place? Is my question. Yeah. If it's like snow, it's like the yeah. Yeah. No, it's not over there. It's just I don't have it. But I know what you're referring to, though. Yeah. Yeah. Yeah, that's so funny. Wait, what? What did you say? I'm just getting, except for the support, I think I'm getting good at it. I'm just wondering. Well, I feel like the rest was a little bit easier. So they're up to what did he say?
So we've got some yellow, so we know it's a second class.
But like, yeah, that's why how we make it. Just like mine, like mine's a little bigger, so that's why I don't know. I mean, it's fine, but at least we just have that that thing was so small that she was like, that's why when I was looking for it, I was like, okay. Nobody did it right.
So that was
Maybe that's what I always know. This is the coolest thing ever.
There's some It's the last one.
Right, yeah, like, yeah.
That is I would treat that. Send you off to leave. I wouldn't say
Maybe she should take
I'll go through this.
open and close. Yeah. She gets the oldest job, which is
Let's, guys. So I want to sum up TJ. And then I wanted to do some of the practicals. Because many did not have our. Who, show of hands, 2 of you have already done it. They left. Who wants to, who's going to do these things? The practical. We're all going to take a shot. Everybody. Great. All right. So, are you going to take it? Good. Okay. So here's how it'll work. I'm going to be, we'll take a short little break, get water out, whatnot. And the room across the hall, I'll take 2 people at a time. If you want, we can do a sign-up sheet. You can decide who goes. It won't take too long. I'm going to use that. And then, you know, the ones that are waiting, you can go back and do some more workshopping.
Thank you.
So, you guys can do it, right?
I think so.
Okay.
Yeah. Thanks.
Yeah.
I know, me too. I'm fucking bored.
Yeah, I don't know. But I feel like if you really want it, you can figure it out. What if it's like not a big deal? I mean, I don't know what her name is.
Okay, so who's my first two victims? Looking for two examinees.
You know what? We're just gonna get that. I guess it's gonna be us.
Like cross bodies.
I'm gonna use my.
They're scaring me here.
Hey, channel the fear. Channel the fear. Capture it.
You can see this is still, I think we're done with that.